This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
Welcome to Talking O&G, a podcast from the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, or RANZCOG. In each episode, we delve into RANZCOG guidelines and research published in the Australian and New Zealand Journal of Obstetrics and Gynaecology, or RANZCOG. But we don't just summarise. We unpack what these insights mean in practice and how they're influencing real-world care across Australia and Aotearoa, New Zealand. I'm Associate Professor Scott White. I'm an obstetrician and maternal fetal medicine specialist based at King Edward Memorial Hospital in Perth. I'm also the editor of the Australian and New Zealand Journal of Obstetrics and Gynaecology, and I'm your host today. In this episode, we're diving into RANZCOG's new clinical guideline on Vasa Praevia, a condition that's rare but carries a high risk to a fetus if it's not picked up before birth, so early diagnosis can be life-saving. Today, we're joined by Dr. Clare O'Loughlin and Dr. Kasia Siwicki, two expert clinicians who helped develop the Vasa Praevia guideline we're exploring today. I'll ask you both to introduce yourselves, and let's start with you, Clare.
My name is Clare O'Loughlin. I'm an obstetrician and gynaecologist based in Wellington in New Zealand. I trained in Ireland and came to New Zealand to do a fellowship in maternal fetal medicine and loved it so much I stayed. My interests are in ultrasound, fetal medicine and in caring for women with high-risk pregnancies. And I was on the guideline development group for the Vasa Praevia guideline.
I'm Dr. Kasia Siwicki, a staff specialist in obstetrics and gynaecology at Alice Springs Hospital in the Northern Territory. I'm also a member of the RANZCOG Women's Health Committee, where we review clinical guidelines during development and following public consultation. This new guideline is a really valuable resource, particularly for those of us working in rural and remote settings, where having a clear, evidence-based approach helps us weigh the benefits and harms in the diagnosis and management of Vasa Praevia.
Thanks, Clare and Kasia, and welcome to the podcast. Let's start with the fundamentals. So what is Vasa Praevia, and why does early detection make such a difference?
So Vasa Praevia is the presence of fetal vessels in the amniotic membranes that are either overlying or in close proximity to the cervix. It's rare, as you have said. It's about 1 in 1,300 pregnancies have Vasa Praevia. And the reason why it's very important to know about is these vessels are unsupported and they're vulnerable to tearing if the membranes rupture or if a woman goes into labour, and that can lead to catastrophic fetal bleeding, and it's got a very high associated perinatal mortality rate of up to 70%. So really important thing to know about antenatally.
Okay, so the guideline now recommends routine screening for Vasa Praevia during the second trimester anatomy scan. So what exactly should those of us who do obstetric ultrasound be looking for at that scan?
So the guideline recommends antenatal screening because we know that a diagnosis of Vasa Praevia antenatally is associated with much better outcomes. So 25 times fewer babies will die, and more than 50% reduction in perinatal mortality or morbidity. The guideline recommends screening at the second trimester morphology scan. So that's looking for conditions that we know are associated with a higher chance of Vasa Praevia, like filamentous cord insertion or multi-lobed placenta or low-lying placenta, and pregnancies where that were conceived through IVF or with multiple pregnancy. And so you're looking for those particular features, but also it gives you an opportunity to have a look for low-lying fetal vessels that are close to the cervix. So that's with ultrasound using colour Doppler as well to identify those vessels. If you have a high index of suspicion or if you haven't been able to see that area clearly, then a transvaginal scan is recommended. Transvaginal scanning is really sensitive and specific for Vasa Praevia, so it's got a 100% sensitivity rate, but a very low false positive rate as well, about 0.2%. And so gives you a diagnosis of Vasa Praevia if those vessels are within 2 centimetres of the cervix, whereas those vessels that are 2 to 5 centimetres away from the cervix are classified as low-lying fetal vessels. It's really important to do a follow-up ultrasound though. So in the third trimester, it's recommended that a follow-up scan's done because somewhere around 15 to 40% of those vessels will actually resolve spontaneously. And we know that low-lying placentas that regress over time are also associated with Vasa Praevia, so it gives you the chance to exclude Vasa Praevia in those pregnancies too.
Is the concept of Vasa Praevia versus low-lying fetal vessels is something that some of us might not be so familiar with. It's a relatively new concept. So, Kasia, can you explain the difference between Vasa Praevia and low-lying fetal vessels and how that distinction changes what you do next?
So there's a lot of variation, as you say, in how Vasa Praevia is defined in the literature. So the goal of this guideline was to really take a practical approach. And the guideline defines Vasa Praevia as fetal vessels that are within 2 centimetres of the internal opening of the cervix, and this cohort is considered high risk. Vessels that are between 2 and 5 centimetres of the internal os are described in the guideline as low-lying fetal vessels. And the idea is that these carry a lower risk, but will still need follow-up imaging. And many of these patients won't require early birth or inpatient care like the Vasa Praevia cohort, but they do continue to need careful monitoring. And these definitions were adopted to try and help balance the benefits and harms of screening. And so the benefits identified included reducing fetal morbidity and mortality through early diagnosis and through supporting shared decision-making around hospitalisation and timing of birth. But the potential harms like misdiagnosis and unnecessary hospital stays or caesarean births were also carefully considered. And this approach therefore allows us to risk stratify, identifying which cases need intervention and which can just be safely followed up later in the pregnancy.
So what's your approach as a clinician? So if I send you an ultrasound report that says this woman's got vessels near the cervix at a 20-week scan, how would you approach that conversation?
My approach is to be clear with the patient, clear about the diagnosis and clear how it's made. And in my setting, it would also be to have confidence and to have confirmed the diagnosis, because obviously I don't want to give the patient the wrong idea. It's really important to be clear about what this means for the pregnancy, including, as Claire mentioned, the possibility that Vasa Praevia may resolve, and clear about the effect it may have on where and when a woman gives birth, particularly in my setting, given the limitations we have compared to, say, a tertiary centre or a urban centre. And so I'll usually talk to my patient about scheduling a follow-up scan. Usually that would be at around 28 to 32 weeks with the possibility of further imaging as needed. And for most women, this scan can happen for my patients in Alice Springs, but if a second opinion is needed, we'll refer to our maternal fetal medicine colleagues in Adelaide, for instance.
It's a big deal having to send a patient from Alice Springs all the way to Adelaide for a scan.
It's a very big deal, yes. But there are times, most of the time, we can just get a second opinion review of the images, and that can be enough to allow us to continue management locally. But if MFM recommends that transfer is required, well, then that's something that most patients are happy to do. And of course, it's supported by PATS in Australia.
Okay, so let's go through a theoretical case study. So if you have a woman who's pregnant with twins, having had IVF, is found at 26 weeks to have fetal vessels lying 1.5 centimetres from the internal cervical os. She has no symptoms. How would you approach her care from this point on, Claire?
So we know that the perinatal mortality rate in singleton pregnancies where you have an antenatal diagnosis of Vasa Praevia is about 0.2%, but it's much higher in twin pregnancies, around like 9.2%. So this is a much higher risk cohort of women. And so you need to individualise the care, taking those additional risk factors into account. So once you've confirmed the diagnosis, that would involve a individualised package of care, which might include recommending routine antenatal admission, because there is some evidence that in twin pregnancies, inpatient monitoring is a bit safer. You might also consider if there's a high chance of preterm birth, and if you're very concerned that there's going to be birth within the next week, you might consider giving antenatal corticosteroids, for example. And you might schedule an earlier caesarean birth if there are additional risk factors of that someone's had a preterm birth before or short cervix. You might think maybe of doing a caesarean around 34 weeks, maybe instead of waiting until 36 weeks. Mm-hmm. So you just have to individualise the care with the knowledge that this is definitely a higher risk pregnancy.
So if you've scanned that patient at 26 weeks and identified sort of vessels 1.5 centimetres from the os, when would you do another scan?
So in the guideline, they recommend between 28 and 32 weeks, and that you would maybe err on the earlier side if there were additional risk factors. I think for this, in this particular case, it'd maybe go somewhere in between, maybe around 30 weeks, unless she's got symptoms of bleeding or some other concerns. And then if the vessels are still within 2 centimetres, that gives you a sure diagnosis of Vasa Praevia, and then you can take things from there.
And that's a huge increase in risk from a singleton pregnancy to a multiple pregnancy.
Yeah.
Why is that?
And they have, they're more complicated pregnancies in general. There's a higher chance of Vasa Praevia, particularly monochorionic twins. And we know that there are associations with other complications with monochorionic twins as well, like selective fetal growth restriction and twin-to-twin transfusion, where you've got Vasa Praevia velamentous insertions. And so some of that probably plays into the overall outcomes in those studies where they compare singletons to twin pregnancies. They just need to be managed a bit more carefully with more vigilant monitoring.
I guess part of the other additional risk is that they're more likely to labour preterm, aren't they?
Exactly.
And unexpectedly, and we're much less able to predict things in twins than in singleton pregnancies.
Yeah, and some of the tools that we have, like cervical lengths, aren't as predictive in twin pregnancies compared to singletons. So your toolbox is a bit smaller.
Twins, more than double trouble.
Yeah.
Kasia, the guidelines suggest that the benefits and risks associated with inpatient versus outpatient care of Vasa Praevia can be discussed with patients, rather than being directive that patients should be admitted to hospital at 32 weeks. What's the thinking behind this recommendation?
I think it's important that we acknowledge that there's really limited data on which to base a firm recommendation, and the approach in the guideline is that the aim of a hospital admission is to reduce the risk to the fetus if bleeding does occur, by allowing for a rapid response. And ideally that would be in a setting where there's access to emergency caesarean neonatal care within a sort of 30-minute window. That said, the decision between inpatient and outpatient management should really carefully weigh up the risks of a rare but obviously very serious event against the impact that hospital admission can have on a woman and her family, especially if it involves staying at a local hospital or being away from home in a remote or even interstate unit.
Can you talk us through how you would manage a patient who prefers not to be admitted to hospital?
We all know from experience, and it's supported by a small body of evidence, that although the priority for women with Vasa Praevia is to have the best possible outcome for their baby, there are other life priorities that play a role in the way women make decisions about these things. And as always in patient care, the management plan needs to be individualised. There are some women, for example, those with twin pregnancies or a short cervix or a history of preterm birth, for whom inpatient care is going to be the highest priority because they're at increased risk. But for someone with a low-risk singleton pregnancy, and if the clinical setting allows, outpatient care can be a reasonable option. What matters is that there's a shared understanding of the risks and benefits, and that the woman feels supported in her decision. Inpatient admission can be disruptive. It can separate women from their families, impact work and financial stability, and it removes them from their support networks at a time when these things might be really crucial to their well-being. And for some women, the financial risk of taking maternity leave early, or concerns about who's going to safely care for their children while they're away, will outweigh any of the perceived associated risks of Vasa Praevia. So it becomes a matter of balance, working with women to develop a plan that meets her needs while also addressing clinical safety. And that might involve setting up a clear safety plan, scheduling more frequent in-person reviews, and having regular conversations about symptoms so that any are reported promptly. It also means keeping the door open to revisit that plan, whether that be around the timing of admission or birth planning as the pregnancy progresses.
Claire, what does the guideline now recommend for the timing of birth, and why that specific window?
So in the research regarding timing of birth with antenatally diagnosed Vasa Praevia, there's a clear reduction in neonatal complications with advancing gestation between 32 and 36 weeks. And then the risks seem to increase up again once you pass 37 weeks. And so that tells us that it appears to be safe to prolong pregnancy until 36 weeks. And so the guidelines recommended scheduled caesarean birth somewhere between 36 plus 0 and 36 plus 6, just balancing those neonatal risks of prematurity with the risk of needing an emergency cesarean section should labour arise as gestation advances. And that's for single to non-complicated asymptomatic women. And like we've discussed already, for those women that have symptoms or other risk factor, then just need to individualise the plan to that particular person.
Yeah. So what are the factors that might make you bring a time to birth forward?
Yeah, so anyone who's got any symptoms, so that might be symptoms of labour, so contractions, any bleeding, women who've got a history of preterm birth or have very short cervix on scan, or say women with multiple pregnancy as well. So anything that increases your chance of preterm labour.
And is there some way that you might, if you're worried about a woman perhaps labouring early, is there any monitoring that you can do that might help guide that decision and that timing?
So there are some studies looking at the role of cervical length and fetal fibronectin in terms of predicting when labour might happen. It's not very clear cut, but that's something that those are tools that you could potentially use to help reassure yourself that prolonging the pregnancy a bit longer is a safe thing to do.
Great, thanks. We'll be back in a moment, but first, a quick message from RANZCOG.
The RANZCOG annual scientific meeting is back for 2025, and this year we're bringing it to Adelaide. Heather, what do you have in store for us?
Thanks, Nisha. We're really looking forward to hosting the RANZCOG ASM, and from the 18th to the 22nd of October, we would like everyone to join us at the Adelaide Convention and Exhibition Centre for 5 inspiring days of learning, insight and also real connection. This year's theme, From Conception to Curtain Call, reflects the full journey of women's health, with sessions covering fertility and pregnancy to menopause and beyond. You'll hear from the global leaders in the field, including Dr. Matthew Leonardi, Dr. Laura McGee and Dr. Linda Brubaker. Plus, we've got some excellent hands-on workshops planned, and don't miss the gala dinner. It's going to be a chance to network, dress up and unwind with colleagues. You can earn 23 CPD hours for attending the full program.
That sounds fabulous. I can't wait to join you in Adelaide.
For anyone who is wanting to join us, visit ranzcogasm.com.au and come visit us in Adelaide.
Looking forward to seeing you all there.
Welcome back. The guideline acknowledges that access to imaging and timely specialist care is not always equal. How do you support women in regional or lower resource environments where referrals and repeat scans may be harder to access?
Everyone working in a rural or remote area will be familiar with the resources that they have access to. Key considerations include whether high-quality scanning is available locally, what the wait times for those scans are, and whether reporting is done by a generalist radiologist or can be referred for a second opinion, ideally by someone with a special interest in the area. It's important to know your tertiary referral centre and to have good relationships with them, and to know the level of support available from the MFM teams in those larger centres, be that for second opinion reviews of scans or to actually send people down to them. Every rural and remote location is also shaped by its own geographic, systemic and social factors, which all influence how and when and who presents for care. So what I try to focus on is identifying risk factors early, arranging timely follow-up and seeking a second opinion from MFM if our local sonographers raise a concern. I then work with each woman to develop a plan that's both appropriate and safe, and make sure that plan is clearly communicated with her care providers.
And there's equally challenges in New Zealand as well with access to high quality scans. Women living in remote areas, cultural and differences as well that need to be addressed. We know that there are poor outcomes in our Wahine, Maori and Pacifica women, and they have barriers to access across all aspects of maternity care. So just ensuring that every woman has access to high quality scan and follow-up, as Kasia has also recommended.
Okay, great, thanks. Before we wrap up, is there one key message that you'd like to leave with RANZCOG members and trainees? Claire?
So I think just thinking about Vasa Praevia, about the risk factors and the importance of universal screening, that double check it in the third trimester to confirm the diagnosis, and that these women and babies can do really well if it's picked up antenatally.
Great. Kasia?
have an index of suspicion and don't be afraid to question the diagnosis or get a second opinion if you're uncertain because of the significant implications for women living rurally and remotely in particular of this diagnosis.
Thanks again to our guests, Dr. Clare O'Loughlin and Dr. Kasia Siwicki. This episode was built around the new RANZCOG Vasa Praevia guideline. You'll find the link in our show notes and on RANZCOG's website under the Statements and Guidelines directory. We'll be back soon with more Talking O&G, exploring the clinical issues, guidelines and research that matter to our members. If you enjoyed this podcast, please rate, review, subscribe and share it with a colleague. It all helps. And remember to log this episode for continuing professional development.